Hypocalcemia is a common pediatric condition encountered across all spectrum and age groups of children. Timely evaluation and management is essential for hypocalcemia, and given the complexity in pathophysiology, an understanding of that is essential to achieve successful outcome with minimal investigations. So we like to focus on the three key questions that are going to be asked by a pediatrician when a child with hypocalcemia comes to us is whether this is hypocalcemia or not, what is the cause of hypocalcemia, and how to go forward in that regard. So all of us are aware about typical symptoms of hypocalcemia, and we know that hypocalcemia is the leading cause of neonatal seizures. It is also an important cause of apnea in newborns and tetany. And in these clinical scenarios, usually we do measure calcium and find hypocalcemia. But there are many other conditions in which hypocalcemia is missed with often disastrous consequences. So we have this 2-month-old boy who presented with respiratory distress, had a huge hepatomegaly, was found to have a reduced cardiac contractility and was diagnosed as dilated cardiomyopathy, was admitted under cardiology, and at that point of time was being managed with digitalis, oxygen and inotropes, when somebody actually had a look at the ECG and found the QTC interval was prolonged, and they found the child had severe hypocalcemia and hypovitaminosis D. Unfortunately, by the time the child was referred to us, it was quite late and there was a problem. Similarly, we have a 12-year-old girl who has seizures for a long time, multiple anti-epileptic drugs. She is refractory on 4 anti-epileptic drugs. Somebody did a CT scan which had showed calcification to begin with, and yet a calcium level was done at a very late stage and was found to have hypocalcemia. We have this 8-year-old boy who presented with severe refractory headache with vomiting, diagnosed initially as migraine, and when it was persistent, somebody did neuroimaging which was normal and fundus which showed baptedema. And the calcium levels were measured which was pretty low, confirming the diagnosis of hypocalcemia related benign intracranial hypertension. 18-month-old boy with stridor, which was a sudden onset. There was no history of fever or a foreign body ingestion. Diagnosed as laryngotracheobronchitis, given nebulized adrenaline and steroids, no improvement, and then calcium levels were found to be extremely low. So hypocalcemia is a commonly missed emergency which will have very adverse effects if we do not pick it up. So calcium should be done in children who have seizures, who present to us with stridor, unexplained cardiac failure, or if there are dystrophic calcification either noted on neuroimaging or subcutaneous skin calcification which are identified. So when do we call as hypocalcemia? And it's important to understand that the cutoffs for hypocalcemia are actually different across ages. So for premature children, we are using a lower cutoff of 7 total and an ionic level of 4 milligrams per deciliter. 1 millimole per liter of calcium is equivalent to 4 milligrams per dl. And as age progresses, we use a cutoff of 8 and 8.4 in most circumstances. While there is confusion as to whether we should use ionic or total calcium, except for hypoalbuminemia or situations of metabolic alkalosis, when the albumin is bound to proteins, are ionic calcium levels more important. Otherwise, total serum calcium levels are reasonably appropriate for diagnosing hypocalcemia. So now when we know that the child has hypocalcemia, the next question that comes to our mind is what is the cause of hypocalcemia? And the cause is understood best when we understand the basic physiology of calcium metabolism. Calcium metabolism is a complex process that involves 3 organs, namely the gut, the bone and the kidney, where we have a fine balance about the amount of calcium which is absorbed, is deposited and resorbed from the bone, and the one which is excreted in the kidney. And to control these 3 key organs, we have 3 players which play an important role, which include the parathyroid hormone, the calcitriol, which are the hyperglycemic hormones, and calcitonin, which is a hypocalcemic hormone. What we need to also understand is that large amount of calcium is actually bound to the bone, and the serum calcium levels that we are detecting are actually not a true reflectors as far as calcium levels are concerned. So now in this regards, PTH is a prime regulator of calcium metabolism. It has a direct effect on kidney where it causes calcium resorption. It has a direct effect on bone, causing bone resorption. So it's the first mechanism by which it causes calcium levels to respond to hypocalcemia. And importantly, it also has a direct effect in conversion of 25 hydroxyvitamin D to 125 dihydroxyvitamin D, which is the active form. So in a way, it indirectly also controls the action of calcitriol. Now, calcitriol or vitamin D has the major effect on gut resorption, and it is the only hormone which is responsible for increasing the proportion of calcium which is absorbed from the gut. It also has a minor effect as far as kidney is concerned. Calcitonin is a minor player in the whole scheme of things, and we can understand that because body wants to really prevent hypocalcemia. So there are two hormones which regulates to prevent hypocalcemia, and since hypocalcemia would not have that different effect, calcitonin has a milder effect. So we should remember that in situations like thyroid cancer, the medullary carcinoma of thyroid, where calcitonin levels are very high, hypercalcemia does not occur. So calcitonin is a minor player, and PTH is the most important player as far as calcium is concerned. Within the schema of things, what we need to remember that another important player which plays a role in calcium metabolism is magnesium, which has an effect on both parathyroid hormone secretion and action. So hypomagnesemia should be considered in every child who has hypocalcemia with unexplained cause and is not responding to calcium supplementation. One player which I have deliberately kept out of the whole scheme is phosphorus, which has a major role not in pathophysiology but in terms of assessment of cause of hypocalcemia. Parathyroid hormone has a direct phosphaturic effect. So every individual who has hypocalcemia should have a rebound hyperparathyroidism, should have increased phosphaturia and hypophosphatemia. So every child with hypocalcemia should be hypophosphatemic. High phosphorus in the setting of hypocalcemia is indicative of either deficiency of parathyroid hormone or the fact that the parathyroid hormone is not working in the setting of either pseudohypoparathyroidism or renal failure. So as the phosphorus levels becomes absolutely important, and within this whole scheme of interplay between the three organs and three hormones, we can widely say that the calcium deficiencies could broadly be because of a problem with the PTH or the problem of vitamin D. And how does the body really sense all the levels of calcium? And that's a very important thing to understand, is the calcium sensing receptor. The calcium sensing receptor is present largely in parathyroid and kidneys. And what it does is that when it senses calcium, it blocks the PTH secretion while it increases urinary calcium secretion. So if there is a problem in the calcium sensing receptor, if the body has an activating mutation of the calcium sensing receptor, it will result in a situation wherein you will have suppressed PTH and high urinary calcium despite having hypocalcemia. So activating mutation of the calcium sensing receptor is a classical case of hypocalcemia with hypercalciuria, which is a rare situation but a direct indicator toward the possibility of a calcium sensing receptor mutation. So from a clinical standpoint, hypocalcemia could be because of increased chelation. And in this regards, phosphate is the most important load, usually in the setting of when we are using a formula milk or a cow's milk, which has high phosphorus content in the newborn period, or if we have release of phosphorus from the cells in the setting of cell lysis like hemolysis, tumor lysis or rhabdomyolysis, you will have a situation where you will have hyperphosphatemia and hypocalcemia. More commonly, we have decreased total calcium, which indirectly again could be vitamin D related or PTH related. And broadly, these two can be distinguished by using a phosphorus level. So thus children who have vitamin D related hypocalcemia will have low or normal phosphorus, while those who have a PTH related problem will have high phosphorus levels. And the PTH related problem could either be because of deficiency of parathyroid hormone in the setting of hypoparathyroidism or hypomagnesemia, or if there is a resistance to PTH in the setting of pseudo-hypoparathyroidism or renal failure. So now when we know about when and why, the question now comes to us is how to approach a child with hypocalcemia. And in this regard, we need to be very careful in terms of assessment, because ideally the calcium and phosphorus levels should be taken in a morning fasting state, because particularly phosphorus is affected by squeezing of samples because it's an intracellular hormone, and also by carbohydrate load. One has to be very careful when assessing parathyroid hormone levels, because unless it is sent on ice or immediately frozen and processed, you will have erroneously low level of PTH. So often we find levels which are very low, which is not because of hypoparathyroidism, but because of inadequate or inappropriate transport of the parathyroid hormone. Also to remember is that in settings of hypoalbuminemia, we have to correct calcium levels, which basically mean that for every 1 gram per liter fall of albumin level, the calcium levels go down by 0.8. So this correction is important if you're not looking at ionic calcium in that regards. And one has to be very careful when we are interpreting alkaline phosphatase and phosphorus levels, because these levels are usually very high in children, and the cutoffs which are given are usually adult cutoffs, which are inappropriate in most situations. So now we have a child with neonatal hypocalcemia. The evaluation should look at the time of onset. First week is largely because of perinatal issues like prematurity, birth asphyxia, or infant of diabetic mother. Between 1 to 3 weeks is usually hypoparathyroidism or hypomagnesemia, and importantly, hypovitaminosis D, which is the most common cause of hypocalcemia in early childhood, does not present before 3 to 4 weeks of life, because there is enough store of vitamin D and calcium, and only after 3 to 4 weeks of life, when the bones suddenly start weakening, when the child becomes hypocalcemic in that regard. You should also look for possibility of infant for diabetic mother, or a history of exchange transfusion, which may be the cause of hypocalcemia in the newborn. Beyond the neonatal period, we have to look for possibilities of renal failure, liver disease, and malabsorption, which usually cause vitamin D related problems. Recurrent infections could be a pointer towards DiGeorge syndrome, which is associated with a few cardiac defects as well as thymic aplasia. Hypocalcemia with alopecia and candidiasis should look for possibility of autoimmune polyendocrinopathy syndromes, while if there is a Albright hereditary osteodystrophy phenotype in the form of round moon facies, short fourth metacarpal, obesity, we should think of a possibility of pseudo-hypoparathyroidism or PTH resistance. The most important thing to look at the initial workup is the phosphorus levels, which is low in vitamin D related causes and high in PTH related causes. Look at creatinine and urinary calcium, because this could give you a direct clue to a calcium sensing receptor mutation. Subsequent workup is largely determined based upon the phosphorus and creatinine levels. So if we have a high phosphorus and a normal creatinine, the most likely possibility is either hypo or pseudo-hypoparathyroidism. So look at the PTH level. In children who have no rickets and have normal calcium, magnesium levels should be measured, while vitamin D levels should be measured in children who have low phosphorus and normal magnesium. So to evaluate a child with hypocalcemia, exclude a phosphorus load, a possibility of cows or formula milk with inappropriate calcium phosphorus ratio, a possibility of a tumor lysis, rhabdomyolysis, or hemolysis. Once that is excluded, look at the phosphorus levels. If the phosphorus is low or normal, it's most likely vitamin D related. Check magnesium levels. If the levels are high, look at creatinine. Children who have low or normal phosphorus with normal magnesium, we should look for vitamin D deficiency, which will be the most common cause. If that is normal, then a rare possibility of vitamin D deficient dependent rickets type 1 or type 2, which are resistant state, should be considered, and we should assess the possibility of calcitriol. Children who have high phosphorus with normal creatinine invariably have a PTH related problem. So look at the parathyroid hormone. If the parathyroid hormone is low, it's most likely hypoparathyroidism. If it's high, it's pseudo-hypoparathyroidism. Now we'll go through some cases to assess the response. So this is a 4-year-old girl with nephrotic syndrome. Calcium is just 7.2, but the child is asymptomatic. So what's the cause of hypocalcemia? So clearly in this setting, we have to look at the albumin level, and what we find that the albumin levels are on the lower side, and we have to correct the serum calcium, which will mean that we have to, for 2 deficit of albumin, multiplied by 0.8, and that becomes 8.8. So this child actually has false hypocalcemia, and it's not a true ionic hypocalcemia. Again, a 4-year-old boy with tetany. We have a low ionic calcium level, we have a high phosphorus level. So we have hypocalcemia and hyperparathyroidism, ruling hyperphosphatemia, which is ruling out a possibility of a vitamin D related problem. And we have a PTH level which is very high, diagnosed as pseudo-hypoparathyroidism. Do you agree with that diagnosis? No. In this setting, what we are seeing is that creatinine was not looked at, and creatinine was actually very high. So, unless and until you check for creatinine, don't rush and do a PTH level in a child with hypocalcemia. 10-year-old boy with seizures, ionic calcium is low, phosphorus is normal, PTH is in the normal range, low normal range one would say. So what should be done? Child was given IV calcium, but there was no response to IV calcium, and then a magnesium level was done which was found to be low. So children who have refractory hypocalcemia should be evaluated for hypomagnesemia in that regards. 3-month-old girl who presented with seizures had low calcium level and a low phosphorus level. PTH level was also very low, was diagnosed as hypoparathyroidism, and in that setting vitamin D was also done, which was found to be undetectable. So this is a very confusing state in which we have both low PTH and a low vitamin D. So what do you think is the most likely diagnosis? What we see here is that phosphorus levels are low, which means that parathyroid hormone is actually there and working. So this level of 2.2 is because it has not been processed properly, was probably sent to a lab and was sitting there for half an hour. So in this regard, it's probably improper transport of the parathyroid hormone and should not be labeled as hypoparathyroidism, which is a lifelong diagnosis in this setting. 1-week-old boy with seizures, born at term, normal birth weight, calcium is very low and phosphorus is high, so indicating a possibility of a PTH related problem. Creatinine level is normal, and once we did a PTH it was low. So this is a classical case of hypoparathyroidism which requires long-term treatment and evaluation for possibility of DiGeorge's syndrome in this regard. 10-year-old boy with seizures, and we can see that this child actually has multiple problems. He had gone to an ophthalmologist earlier for which a cataract was detected and underwent a cataract surgery. He had gone to a dermatologist with a skin problem, which was a nodule which used to appear multiple times. Finally, when he went to a neurologist with seizures, he was found to have multiple intracranial calcifications. And at that point, they were referred for evaluation of endocrine, and we saw that this child actually had short fourth metacarpal, as we can see out here. And the diagnosis was very clear: hypocalcemia, hyperphosphatemia, high PTH. So this was the case of pseudo-hypoparathyroidism, who had to go to 4 specialists who make a diagnosis. So hypocalcemia is a common thing which is often missed with disastrous consequences. Now once we make a diagnosis, treatment is relatively easy. You start off with treating with ionic calcium is less than 3, you have to give IV calcium in that regards. Calcium gluconate should be given diluted, should be given in a slow infusion, and we should avoid extravasation, otherwise there will be skin necrosis in that regards. The usual dose is to start off with 1 ml per kg followed by 80 milligrams per kilogram per day is the calcium. It can be given as an infusion in most situations. Once the child is stabilized, we reduce the dose to around 75% on the next day, then reduce to 50% and add oral calcium. Day 3 we stop and start on activated vitamin D. Often we forget to start activated vitamin D, and that has significant implications as far as hypocalcemia is concerned. What about calcium? We need to give around 40 to 80 milligrams per kilogram per day, and preferably carbonate and citrate forms. Calcium phosphate should be avoided, particularly if there is a PTH related problem. Should be given pre-meal for ensuring best absorption and given as 3 divided doses in most cases. So just to summarize about hypocalcemia, we should always think low calcium levels in children who have seizures, unexplained cardiac involvement or stridor. Phosphorus is the most important test to begin with. We should give rapid correction if the child is symptomatic, and activated vitamin D is very important in children who have vitamin D deficiency and acute hypocalcemia.